Hello and welcome. Thank you so much for taking the time to join us today. We really appreciate you joining us in today's webinar. On behalf of Altus Learn, we'd like to welcome you to this presentation, Managing SAR in Today's MR. My name is Chris Giordano. Just a little background about myself. I've been in the field of MR since 1995. I've been blessed to be registered and licensed in MR since 1997. I currently am in the role of imaging manager in a hospital outpatient center where we perform on 4 separate MR machines, close to 20,000 MR procedures a year. We're a busy place that we are fortunate to be able to image a lot of different types of cases, some advanced imaging, some basic imaging. And it's a result of the teaching facility and the myriad of texts that have come through our doors that have really developed a passion for the teaching aspect and being able to bring content to the MR community. We hope that you'll find this session informative and very valuable to your day in and day out workday. Just a little bit of housekeeping for today's session. This will be eligible for 1 AHRA approved Category A credit for use with your ARRT credential renewal. We also have additional content developed by Better MRI on the Altus Learn site, where there are modules that were designed with the MR technologist in mind. We hope that you'll get to take a look at some of that content, give us valuable feedback on that content, and as well as today's session as well. So on to today's topic, where we will delve basically into MRI, the 3 fields in MRI. And our primary focus will be centered on the RF field and the management of the heat that is a byproduct of MR, making our patients more comfortable, free of any injury or harm is the primary focus of today's discussion. So we will begin our first agenda item with discussing the different types of magnetic fields that are required to form an image. I like to really break it down into the basic 3 fields of magnetic field, or static magnetic field, the RF or resonance, part of magnetic resonance imaging, and then lastly, the imaging aspect of magnetic resonance imaging performed by our gradient fields. So specifically, the static magnetic field, most common, a 1.5 Tesla magnet, 3 Tesla higher field strength, aligns protons, establishes magnetism. This static field, defined as a stationary and movable field, is the concern when we look at the torpedo effect or things that could pull or entry into the MR environment. The resonance field, radio frequency pulse, that's used to excite protons and elicit signal from our patient tissue. Lastly, the gradient fields are used to determine spatial resolution, image orientation, and field size, where the detail in our image is acquired. Typically in MR, we look at the spatial resolution, defined as detail, how much clarity in an image, compared to temporal resolution, where so much research and effort is put into accelerating MR. We're going to have a future presentation where we will discuss speed and motion correction in MR and the various aspects or techniques that are available to the MR technologist. So, I've been doing MR for over 20 years. It used to be that one particular sequence would take 12, 13 minutes. Now, current day MR and modern day systems, we perform, let's just say as an example in our facility, an entire breast MRI exam in under 12 minutes. If it's just a follow-up, we can acquire the entire exam in 10 minutes. So entire exams with tremendous detail, 512 resolution, 1 by 1 by 1 matrix, and acquiring an entire exam in 10 to 12 minutes. So detail, absolutely required in the diagnostic value and criteria placed in MR, but speed in getting an entire exam done in a more timely manner. So specifically, the magnetic portion of magnetic resonance imaging refers to our static magnetic field. What are our concerns with this static magnetic field? The biological effects or the missile or the torpedo effect. Unfortunately, there is still, this is 2017, this is still the healthcare as a whole looks at an MR machine as, well, if it's not scanning, the magnetic field is not on. And that's where a tremendous amount of injuries do occur. This missile or torpedo effect, proportional to the ferrous properties of the object, the size of the object, and the strength of the magnetic field. So a non-MR compatible MR steel stretcher going in a 3 Tesla room will have a great deal of pull or torpedo effect and potential injury that could occur. Safety for patients' implanted hardware, RF or battery operated device malfunction. This static magnetic field is also known as B0. The direction of the magnetic field is reliant on the design of the magnet. Typically, an open system is designed or set up with a vertical field direction. Great for patients that are claustrophobic, but not compatible with those patients that have, for instance, a loop recorder, where a loop recorder is only approved for use via the manufacturer guidelines in a horizontal closed bore system. So the direction is very important to the MR technologist in establishing safety in our patients. FDA limits for the magnetic field strength, 4 Tesla for everyone, the entire population, but it's limited to 8 Tesla for those that are over 1 month of age. So unable to image on 8 Tesla, newborns, neonates. So FDA limits. Specific to the RF radio frequency field, the resonance portion of magnetic resonance imaging, the RF coils installed inside the MR scanner are positioned closest to the patient and therefore have the most association with heating due to electrical induction. These RF coils that are right on the inside of the magnet closest to the patient will lead to the most heat. So therefore, biological effects or risk, thermal heating, SAR absorption, we'll define and discuss this. The primary patient burns and tissue heating occur from RF techniques, excessive RF implementation. Another concern is in pregnant patients, overall warmth and temperature rise in amniotic fluid. What does the FDA set as limits for whole body SAR? 4 watts per kilogram, over 15 minutes of scanning, but keep in mind this is on a per sequence basis, not an entire exam. So the RF magnetic field briefly is used to excite those proton spins and produce resonance. It's taking the vector that was established by the static magnetic field and eliciting a signal out of the patient. This is known as the secondary magnetic field, or B1. The RF field is a rotating magnetic field that is applied for a short designated time, and this is always perpendicular to the plane B0. This time of the application of RF, our transmit bandwidth, not to be confused with our receiver bandwidth, can play a huge role in the type of sequence that we select and its impact on SAR and heat in our patient. And we'll discuss that further shortly. RF is transmitted at the specific frequency to create resonance according to the Larmor frequency and is powered by the RF amplifier. Keep in mind that the RF pulse is doubled, and we're going to talk a great deal about this RF pulse. From 90 to 180, 4 times the power is used. This amount of power creates more heat in the patient. So what are the risks of this RF field? SAR limitations, tissue heating, again, temperature rise. So when we start that sequence, we're initiating RF excitation. Chemical saturation, pre-saturation, bands or slabs are all mechanisms of using more RF that can lead to increased patient heating. Particularly, the fast-spin echo sequence is the one of most concern due to multiple echo train links leading to potential increases in tissue heating. So fast-spin echo, the guiltiest offender when it comes to the amount of thermal induction in our patient. So the last field in MR imaging is our gradient magnetic field, also doing business as TVMF, or time varying magnetic fields. The biological effects or risks of this field are quite different than the RF field. They're quite different in that there isn't as much of a concern of heating, warmth, or thermal induction, but instead, the gradient field can lead to muscle contractions, peripheral nerve stimulation, mild cutaneous sensations, cardiac arrhythmias, or those visual light flashes where patients say they're seeing stars, identified as magnetophosphines. Say that 5 times fast. The FDA limit on the gradient magnetic field, what would be the threshold? There isn't any set number or level except for the definition that the FDA sets of peripheral nerve stimulation up to levels that the patient can tolerate. We have a specific patient that we image recurrently in our facility. She always is imaged on 3 Tesla due to the detail and the seizure disorder that she presents with. And she continually presses the call bell on our susceptibility weighted imaging sequence, the SWI. And in her words, she feels the sequence coursing through her. We then stop the exam and we will instead replace that sequence with a more routine traditional T2 star gradient echo sequence to try to serve the same purpose with less detail. This is the exact definition of that FDA limit. It is up to the level that the patient can tolerate. So this is the gradient magnetic field interaction and an example of a patient reaching that threshold. They're responsible for the translation of that signal into spatial encoding, the formation of gradient echoes, the acquisition of our detail in the image acquired by the gradient magnetic fields. So again, FDA sets peripheral nerve stimulation up to levels that the patient can tolerate. So those are our 3 fields, but our primary vein of concentration for this broadcast is on the RF field. The RF exposure in our patient is measured as either an increase in body temperature or as the specific absorption rate. This will be tied into the modes that we operate on, but it depends on the induced field, pulse duty cycle, tissue density, conductivity, and the patient size. You will have different SAR levels based on varying patient weights and sizes. So the SAR, or rate of energy deposition, is expressed per kilogram of body weight. Think again, power per pound. It increases with field strength, sequence selection, and even coil type. So the MR system operating modes are ways in which we can control or establish which modes the system will operate and the thresholds of both temperature and SAR. So the first level controlled mode would be the SAR levels that may cause physiological stress, 1 degree Celsius or up to 4 watts per kilogram. This is typically fast scanning modes, right, that can reach thresholds of heat or temperature rise. Most systems are going to stay within normal operating mode, considered safe for all patients, regardless of their condition. only a temperature rise of up to 0.5 degrees Celsius, or SAR limitations of up to 2 watts per kilogram. That would be normal operating mode, not fast scanning, not fast sequences on your scanner. Second level controlled mode, um, one in which parameters may reach values that produce significant risk for patients. Now the temperature rise is greater than 1 degree Celsius and exceeds 4 watts per kilogram. So the risk factors of conditions in which your patient may increase body temperature, they may be have a condition of cardiovascular disease, they may be diabetic, hypertensive, again, obesity or geriatrics, patients that present with fever or infection, obviously pregnancy, as the risk for fetal heating is greater, simply a patient with a cast, and the insulated heat trap where you're containing and not allowing heat to escape. Also a risk factor would be non-communicative patients, so those that are sedated, unconscious, or with altered mental status, those that can't alert you, the technologist, that they're experiencing warmth or heat. Also patients with limited perspiration ability, and patients with metallic implants, tattoos, newer tattoos, piercings. So those are patients where their conditions can risk increasing body temperature. Medication-induced heat potential, patients on beta blockers, those on diuretics or sedatives, muscle relaxers, amphetamines. So your diabetic patient presenting with a fever or infection in the spine who is overweight and on sedatives for claustrophobia will have a tremendous amount of heat for that lumbar spine exam, where we use all fast-spin echo sequences, creating a tremendous amount of RF thermal induction. This is where we can identify almost pre-scan that certain patients are at greater risk than others. So things that we want to keep in mind. Positioning, always the number one requirement towards ensuring accurate enough SAR measurements on your scanner is to enter the patient's weight correctly upon the beginning of the exam. This enables the MR system to allot accurate SAR measurements, again, for the most part, that there can be appropriate corrective measures taken when those thresholds are exceeded. I used to work at a center where they entered 90 kilos for everyone, and again, just inappropriate when it comes to inaccurate or inappropriate, incorrect SAR measurements on the system. Other ways that we can position better, using vendor-specific positioning pads, separating the patient from the magnet bore edges, especially in the bariatric patient population. Larger patient always equals increased SAR. So use the bore pads or vendor-specific positioning pads to create a separation between patient and the magnet bore. Particularly in exams with high SAR, so spine exams, long bone extremity work with a lot of slices and a lot of fast-spin echo imaging, pelvic imaging, or any combination of these. Cancer patient with a lumbar and thigh exam, very problematic at the onset due to the amount of procedures that will generate increased SAR. So be mindful of sheet and blanket use. In our facility in particular, we have a blanket warmer. It's great for patient satisfaction, but for those patients that are very cold, the utilization of a blanket warmer can lead to the potential for danger in SAR absorption. Create a means for the heat to escape, as SAR and body temperature correlate to the amount of thermal induction minus escaped heat. So you want to look at the ability to give the patient's tissue and core body temperature the ability for heat to escape, that it's not contained and staying within the patient. Also, positioning or more environmental is ensuring consistent room temperatures. We want to keep that room temperature cool enough to reduce the RF heating effects and also balance the humidity at 50 to 70%. Important aspects environmentally in ensuring the most accurate, again, reduction of thermal induction in your patient. Another aspect for us, the technologist, in ensuring the ability to manage SAR better, would be to consider reordering your sequences. Fast-spin echo, that long train of very powerful 180-degree refocusing pulses, those are the sequences that are your, I want to call them the guilty SAR fenders, if SAR fender's a word, creating the most heat. Those fast-spin echo sequences can be extremely problematic in compounded heat. Most vendors, modern vendors, are using the SED rate, which is SAR over time, where it's an accumulated dose, and exceeding that in fast-spin echo sequences, lumbar spine, and other exams, and multiple spine exams in the same day can be problematic from SAR deposition. So energy deposition from an RF pulse is proportional to the square of the flip angle. So 180-degree refocusing pulse is 4 times more powerful than our initial 90 excitation. Shortly, we're going to talk about one of my favorite mechanisms in reducing the amount of that 180-degree refocusing pulse. So our typical echo train length or TSE factor ranges for T1, it's typically between 3 and 6 on most scanners. Proton density, we keep it 6 to maybe 18 or so. But in T2 weighted sequences, we can really run into a tremendously large echo train length, 10 to sometimes even 30 or 40 on an echo train length, which can lead to a tremendous amount of deposition and thermal induction in our patient. So be mindful of, again, sequence balancing in that regard. Problematic SAR parameters, and where do we run into trouble? How is SAR compounded? What are the things that we look for? Obviously, field strength. Same patient on the 1.5 Tesla, same parameters, will have an increased SAR potential in a 3T system. So field strength SAR is proportional to the power of 2 for the resonant frequency. So when we double field strength, this results in a 4-fold increase in SAR potential. Second problematic SAR parameter, proportional to the patient size and duty cycle. Larger patient, bariatric population, more problematic at higher field strength. Third problematic SAR parameter, increases in flip angle, increase SAR. So any increase in flip angle is going to increase the power in the patient. One of the more obvious isn't exactly a parameter, but rather a sequence selection by the MR technologist. We're all in a rush, and very often we are behind schedule. So we have a tendency to reach for the faster protocols. Use with caution. Employing faster protocols uses a shorter RF transmit pulse. This in turn increases SAR. So the time the RF pulse is on reflects the type of sequence selected for excitation. A low SAR sequence has a longer transmit RF pulse, whereas a fast sequence uses a 1.2 approximately millisecond transmit RF pulse. This results in an imperfect slice profile, resulting in larger SAR thermal induction. Reducing TR with increased slices will also, again, increase SAR. Something to watch for. We do want to have more T1 weighting, so we may reduce TR, but watch for your impact that it has on your SAR values. Again, we want to save time, so our mechanism, we may reach for increasing the echo train length. Although it's a faster sequence, additional powerful 180-degree pulses create more heat. So things to watch for. Let's look at the mechanisms or the means in how we, the MR technologists, can employ the safest imaging. How can we best manage SAR? and manage SAR effectively. We can reduce the number of concatenations or acquisitions if you're on GE or packages on Philips. This will result in longer scan times, but increased TR will reduce SAR levels. I will say use with caution in T1 weighted sequences, as again, the longer TRs will reduce your overall T1 contrast or weighting. Reducing the number of slices while maintaining the TR factor is another means of reducing your overall SAR value, but I will say caution in smaller anatomic regions, IAC in particular, wrist, things of that nature. Reduce in echo train length. I will caution you in T2 weighted sequences, as this will position your effective TE at a shorter TE value, so use with caution. But a reduction in echo train length will aid in reducing your SAR. The mechanism employed in our facility when we reduce the echo train length in T2, we tend to then enable driven equilibrium or drive that will help us to have an increase in fluid intensity. Fifth mechanism of managing SAR to employ longer and lower amplitude RF pulses, what we just discussed. This is the base behind the low SAR sequence, but the drawback is this will result in longer minimum required TE values, which will require a longer TR, and the end result or the end product is that this will increase scan time. Another mechanism of reducing SAR, use a TR coil, transmit-receive coil, instead of a phased array coil. Think of a VNS stimulator or certain neurostimulators where we have to, for safety, transmit and receive RF only inside the coil. So we'll image a seizure patient with a VNS stimulator turned off. What does it result in? Longer scan times, but always there'll be a lot less SAR risk factors with that. One of the more common and more modern mechanisms of a reduction in SAR is our MRI BOGO offer. 7-Eleven is definitely not the only one with a buy one, get one free. Employing parallel imaging is really a novel technique that's been around for quite a number of years, but I feel is very underutilized in the MR community. By employing parallel imaging, we're using the coil channels to lessen the workload of the phase encoding gradient. This will in turn reduce the number of RF excitations. In addition to reducing SAR, this will accelerate scan time significantly. Very advantageous, especially at higher field strengths, 3T or so, where the signal loss is not as noticeable. We use tremendous parallel imaging in both the slice and phase direction on a 1.5T digital machine, where again, breast MR, 10 to 12 minutes maximum for an entire exam at very high resolution. Parallel imaging, lowering your SAR, and also enabling faster scan time. That's one of the few buy one, get one frees in MR land. Other mechanisms of reducing SAR, and one of probably my favorite techniques, is a flip angle modulation technique. By utilizing or employing a decreased flip angle and reducing the thermal induction of the 180-degree refocusing pulses, we're reducing the amount of power that is imparted to our patient. The flip angle sweep modulations utilize a larger flip angle positioned in the center of case space where predominant contrast resides, and tapering the flip angle as case space fills towards the edges. This will aid in preserving T2 contrast while reducing SAR, and in some cases boosting signal and accelerating scan time. This technique, vendor specific, Philips is under the contrast tab for refocusing control, Siemens HyperEcho or Restore, GE Verse or Tailored RF, Toshiba T2 Plus. One of the easiest methods in lowering your SARs in your patients and saving you scan time, very often boosting signal in your images. Consult your MR system manufacturer and the clinical education professionals for advice on its use and limitations. Typically in our facility, we don't employ this in brain fast-spin echo sequences, as SAR is inherently lower in brain exams. This is not applicable to gradient echo sequences, as there are no refocusing pulses. Not as crucial in STIR. The inherently longer TRs in STIR from lengthy TI times, particularly at high field strengths, typically realizes approximately a 15% alteration in your image contrast, so do use this with caution. And the recommendation from most professionals is to not employ a refocusing flip angle below 70 degrees. So really great mechanisms or methods of employing that at your scanner. Various implants that are used will, based on manufacturer guidelines, will give you an idea as to the SAR levels that are used, so that we as an MR technologist can stay within those regulations. So now that we have discussed the definition of SAR, we have conquered the management of SAR, it's important to me that we clinically apply the management of SAR to actual patient conditional implants. Take, for instance, a programmable CSF shunt. We see this most often in patients with Chiari malformation or patients with hydrocephalus, and this is a treatment option for hydrocephalus. These valves are conditional for use in the MR environment, but a lot of what we do and our time constraint in the modality of MR is the researching of these implants and then applying them safely to our patients. So based on the information that's gleaned from researching this device, it states that MRI can be performed at any time after implantation. We are allowed to image these devices on a static magnetic field of 3 Tesla or less, utilizing a spatial gradient of 720 Gauss per centimeter or less. One of the key factors is that we limit the exposure of whole body SAR to 3 watts per kilogram for 15 minutes. An additional requirement for use of exposure to the magnetic fields is verifying the valve setting after the MR procedure. The implanting neurosurgeon or neurologist will control the pressure setting of this particular device with a handheld magnet. Obviously, the MR machines we've already established are utilizing very strong magnetic fields, so the programmable CSF shunt needs to be verified as far as its pressure setting following the MR procedure. Statement as far as the testing: whole body STAR of 3 watts per kilogram, 15 minutes of MR scanning, realized a 0.4 degree Celsius temperature increase. So the application is we stay within these guidelines. Moving on to a routine, let's say, coronary stent, like the Resolute drug-eluting stent. This Resolute integrity stent, total length of 120 millimeters, is MR conditional. And again, these are MR conditional guidelines set forth by those that have tested these devices and established by the manufacturer guidelines. Static magnetic field 1.5 or 3T, gradient field of 1,000 Gauss per centimeter. Note that here the statement is that the SAR has to remain 2 watts per kilogram or less and under normal operating mode only for 15 minutes of scanning per sequence. In this particular example, a patient with this coronary stent were not able to utilize faster scanning techniques like first level operating mode. So we remain under normal operating mode. Yes, the sequence scan time will be usually minimally longer, but SAR of 2 watts per kilogram or less are these specific manufacturer guidelines to stay within safety. A implant, like a spinal cord stimulator, can result in more strict guidelines of both the machine itself, usually horizontal closed bore system, never in a vertical field system, and then also take note in the center paragraph on the left, or 1.1 watts per kilogram for 25 minutes of imaging. Here you're looking at never compatibility with 3T and very low SARs that we have to ensure to make sure that we keep these patients safe. This is a prime example of we don't want to create any damage to both the device inside the patient or any burning or heating that can occur. So we really want to make sure that we stay within the specifications that have been set forth by the manufacturer guidelines. 1.1 watts per kilogram is a very low SAR rate, important to employ some of the techniques we've just discussed in ensuring compatibility with this particular SAR level for a patient with this particular implant. Very crucial for safe scanning. Another particular example is our Revo SureScan MRI. Again, when we started out in MR, 20, 30 years ago, pacemakers, defibrillators, implants of that nature were never able to be imaged. Now, under strict MRI conditions, there is compatibility with MR scanning. Horizontal cylindrical bore magnets. So again, no compatibility to a vertical field. Has to be a horizontal static magnetic field. And then here, 1.5 Tesla, newer approval, been granted to 3 Tesla under certain conditions. Scanner must be operated, again, in normal operating mode, and the SAR has to be maintained at 2 watts per kilogram or less. Head SAR must be kept to less than or equal to 3.2 watts per kilogram. Additional manufacturer guidelines state that proper patient monitoring must be provided during the MR scan. This includes visual and verbal contact, as well as pulse ox or ECG waveform, tracing of the waveform to ensure that there's no ill effect to this patient's implanted MRI conditional MR pacemaker. So these are examples of clinically researching and applying the management of SAR with some of today's implants in today's MR environment. So some of the newer labeling in MR pacemakers and other MR conditional devices, there's a transition in not only SAR, and we've established those techniques and the interactions controlling SAR and affecting SAR, but now using a newer terminology that is labeled as B1 and RMS. So B1 and RMS is not so much patient dependent as it is parameter driven. Whereas we can build, let's just say, a low SAR sequence in the traditional sense, and the actual system designated SAR levels will change from patient to patient based on patient size and a few other factors, and may not be as specifically and detailed accurate. B1 and RMS is more or less a setting that ensures the parameters of your sequences are within specification of a particular device. So labeling, and this is taken directly from, as an MR tech, we would research a particular implant, and in this particular case we are researching an Advisa MRI pacemaker and researching what Medtronic has to say as far as conditions for use. As a disclaimer, let me state that there is no financial support by any particular vendor, nor is just Altus Learn is the only support of this particular production. So that being said, In researching as an MR tech, in researching Advisa MRI, and looking at the conditions for use with a pacemaker and how we would implement this, we're taking the labeling to be a little more detailed than simply the SAR settings. So using B1 RMS when we landmark or center below C7, so it's not a head exam, SAR must be limited to the normal operating mode in a 1.5 Tesla system. Again, no first level mode, no fast scanning techniques. B1 and RMS, in this case, in this particular research that we've done as an MR technologist, applies to 3T only. So when utilizing B1 and RMS as a condition of use, we can then utilize normal or first level for SAR, but the displayed B1 and RMS value for each scan is not to exceed 2.8 microtesla. So again, these conditions for use, newer systems, I believe Philips uses 2016 or beyond, that B1 and RMS will be displayed coinciding with our SAR levels. 3T, most of our protocols and all of the parameters that we've discussed in limiting and mitigating SAR absorption in our patients would not conflict in compliance with the 2.8 microtesla B1 and RMS condition for use for this particular implant. General rule of thumb, stating from the manufacturer guidelines, the higher the estimated SAR, the higher the likelihood that some modifications would need to be made. Also, and again, as previously stated here in this discussion, when we are utilizing local TR coils or transmit receive coils, there is no restriction for B1 and RMS. There is no risk of an excess of thermal induction. So an example on the scanner, when we discussed the flip angle modulation techniques, we discussed the ability to take those 180-degree refocusing pulses and instead employing a lesser flip angle in that regard. In this case, the application of 120-degree refocusing flip angle modulation, tremendous SAR levels. So on the right column of this particular screenshot of an example, our SAR whole body is 1.3 watts per kilogram, well within specifications of keeping a low SAR setting. But below that, the B1 and RMS at 1.42 microtesla. So you're seeing a transition in current modern day systems and transitioning from not only just the recording of SAR, accumulating SAR to two lines below that, the SED, where it's the accumulated dose over sequencing, but then also adding that last and final piece, the B1 and RMS, so that we can ensure compatibility with implanted devices and the safety in our patients. You'll note that below that highlighted red line at PNS level, that's where the interactions of the gradient magnetic field, our time-varying magnetic field, can be of concern, our PNS level. So all of these are indicators or a measure of safety in our patients. So again, Medtronic states that their summary is that there's now expanded labeling to include 3T under certain conditions for use. B1 and RMS, if indicated on your scanner, gives you clearance to landmark or center below C7. They insist that the conditions for use state that we use less than or equal to 2.8 microtesla, and we can implement either normal or first level controlled SAR mode. B1 and RMS, again, gives us a little more of a flexibility in our pulse sequence and parameter selection, whereas the setting for SAR is driven by patient size and other factors that can adjust that parameter. Once a sequence has been modified to have a B1 and RMS value of 2.8 microtesla or less, we can then save that sequence in our exam card or protocol base for which to refer to at a later time, ensuring compatibility with that particular device. So it really helps to have a parameter saved for safety mechanism as opposed to being adjusted on a patient-by-patient basis. So B1 and RMS is the newest mode and mechanism of MR safety and ensuring the least amount of SAR to our patients. So again, I would like to thank you for joining us today. On behalf of Altus Learn, we appreciate you taking your time out of your day today. Please note that our content, as far as reference material and sources of reference for this broadcast, will be found within this discussion and within this document. We are going to shortly open up this time for a question and answer session, where if you have any particular questions regarding this content in this module, you can certainly feel free to ask, and I hope that I can answer those questions to the best of my ability. Again, I so thank you for joining us today, taking time out of your day. We hope that you learned a lot, and we hope that this is something that you can apply to your patients and to your workday in having a safer patient environment. Thank you again. Really appreciate it.